All right, so I think this will be our last video. We'll see how it goes. Continuing with our conversation about etiology. So we've talked about all the biological stuff, which is going to be important in both sets of disorders, but especially important in bipolar disorder. And so here, these social and psychological factors are going to focus a lot more on depressive disorders, where they play more of a role. And that has to do with just how heritable a biological bipolar disorder is. And so we're talking about social factors, because we're going to talk about social factors and psychological factors. Social factors are things in the person's environment, whereas psychological factors are internal processes for the person. So first, we're going to talk about environmental or social factor etiology. And this is going to, kind of echo some things we've talked about before, which is that stressful life events seem to be correlated with higher risk of depression. That seems to be both in the immediate sense when something stressful right now is happening, right? So during COVID, I'm sure we're going to find that in the months following COVID, we had higher rates of depression in the population. But it also that effect might linger into 2021 or 2022, because we also know we have kind of these short-term but less immediate effects of stress. But we also have an effect of chronic life stress. So people the cumulative effect of stress, for example. So people following COVID, the people most at risk for depression are going to be people who prior to COVID were also experiencing stress, perhaps throughout their lives. So, and that might be stress like poverty or other environmental stressors in that way. Stressors seem to play more of a role in predicting whether you're going to have a first episode of depression. And then after that first episode, recent stressors seem to be less important. And we wonder whether stressors can prime a vulnerability. So you have an underlying vulnerability to depression. Without major stressors, you may never have become depressed. Once you have that first depression, then the stressor plays a bigger role in that onset. If you can avoid that first episode, you might have avoided future episodes as well. Going along with that and hearkening back to earlier conversations is the lack of social support we see at higher rates in people who have depression or who develop depression. So social support is a protective factor. And then I don't know if we talked about this before, but there's something called expressed emotion, which is about how emotionally reactive, essentially, and expressive the people in your environment are. So some families my family tends to be, the family I grew up in tends to be fairly emotionally expressive. And that means that you're more likely to observe them laughing loud, crying, getting visibly angry or verbally, kind of that their emotion is not very hidden. Whereas my husband grew up in a family where their emotion was pretty hidden. It's really hard to detect if somebody's mad, but also hard to detect if they're really, really happy. It's just a kind of narrow range of emotional expression. If you have depression, if you've had depression, an episode of depression, and you live in a high expressed emotion environment, you're more at risk for later episodes of depression, and that probably has to do with the brittleness. Expressed emotion is not necessarily a bad thing, but if you're emotionally brittle and not emotionally resilient, then it might be burdensome in some way, and so that's kind of probably the role that plays. All right. And then the psychological factors, right? These are the internal things. We know in terms of personality traits that people who become depressed or are at risk for becoming depressed have higher levels of what we call neuroticism, but this is a better way of talking about this is emotional reactivity. And that really feels like it doesn't need much explanation, like that is of course true. And then, right, there's a whole lot of effort put into research and discussion of cognition, how we think, and how that affects the likelihood of becoming depressed. And so we have first Aaron Beck, who talked about the negative triad. And a negative triad is having negative ideas about yourself, the world around you, and the future. And that comes along also with distortions or cognitive biases, the higher likelihood of having negative memories and interpreting your past experience in negative ways. And so, for example, somebody who's very pessimistic or somebody who looks back on their childhood and says, things were never good, and we never had a lot of money, and they may have a sibling who has very different memories, and he says, well, we didn't have money, but things were like really fun, and so just it's not that they're making it up, it's that we're more likely to pay attention to the negative things and therefore more likely to form memories of them. Um, the negative views of self, world, and future is, that, I'm not a very good person, or I'm not a very worthful person, or I'm not very smart, maybe is one more specific way. Right, so bad things happen to me. The world really sucks and it's a bad place, and there's no reason to think that the future is going to be any better. That's that negative triad, negative views of all of those things. Um, the reality is that if you're having those negative views, that you're just more at risk for developing depressive symptoms. Um, it also is probably true that people who have a vulnerability to depression may be at a higher risk for developing this negative triad, and it's important to see that it could run in both directions. Um, we also we talked about hopelessness a lot in this chapter. We do see higher rates of hopelessness in people who are at risk for depression, and that they make attributions. So attributions are thinking about what causes something to happen, and people who are depressed or at risk for depression make more stable and global negative attributions. So if you fail a test, right, a stable, right, negative attribution might be, I always fail tests. And not just do I always fail tests, but I suck at everything. That would be the global attribution. And the other one that I haven't listed here for some reason is about the internal stable and global attributions of negative events. That I fail a test and it's my fault. I always do badly on things, and I will always do badly on things, right? The internal stable and global attributions. We also see in people who are depressed as higher rates of rumination, and I make the distinction for my clients between productive thinking and ruminating thinking. Productive thinking is where you're problem solving, or that the thinking has an endpoint when you figure something out or solve a problem. Whereas ruminating is just going over and over and over things that don't have productive value. I have a client right now who've been talking a lot about rumination. She runs through every bad scenario that might happen when she has to confront somebody, for example. And she's not doing that with the, in a practice kind of way. She's just kind of living in events that haven't even happened. And people sometimes do that with past events also, just going back over and over and over bad things that have happened or embarrassing things that have happened. And there's not a point to it other than kind of bathing in those thoughts. And that is also a risk for depression. In the bipolar disorders, we don't really have the same focus on social and psychological factors because they're so heritable. The triggers of depressive disorders are the same, so people are less likely to have multiple episodes of mania, for example, or of depression during that accompany a bipolar disorder if they've got low stress and high social supports. It's important that people with bipolar disorder address sleep disruption as it starts happening, or avoid kind of external things that cause sleep disruption, because having disrupted sleep can also make you more at risk for bipolar disorders. And so we're going to talk really briefly about treatment, because treatment really is going to be reactive to the etiology we just talked about. And so if we think about biological treatment, hang on a second. So if we think about biological treatment when it comes to depression, we are going to be looking at a medication that affects serotonin, norepinephrine, and dopamine for the reasons we talked about. And so that's going to include SSRIs, which are those serotonin reuptake inhibitors, as well as SNRIs, which are serotonin and norepinephrine reuptake inhibitors. And those are going to be the primary medications that that we focus on right now. In the older medications are MAOIs and tricyclics. They work really well, but they have side effects that are really hard to tolerate, so they don't get prescribed very much right now. And what we do know is that a combination of psychotherapy and meds, research shows us really clearly that that's the most effective treatment for depression. Um, and so I'm gonna, and so I just want to look quick. There's a Wikipedia page that's a pretty good list of antidepressants, and just you can take a look at kind of the name brands that you might be familiar with. So in blue is under each heading is the generic name, but then you can see the name brands that you're more likely to be familiar with, if only from television commercials, right? So we've got those SSRIs and the SNRIs. And then we've got things like Vibrant and Trintellix, which are serotonin modulators and stimulators, and they can be really useful for people whose primary symptoms are inactivity and lack of motivation, right? And then we've got some that are just NRIs. We don't prescribe these so much in the United States. I think they might be more popular in other places. And then Wellbutrin, which you might be familiar with. It's used for many things, including smoking cessation, but also is used to treat depression. Works on both norepinephrine and dopamine. So for people that either don't have effect or can't tolerate for some reason the SSRIs, those are a really good option. And then we do have these others, but the ones up here are the ones most likely to be prescribed. All right, so for back here, the other biological treatment that we can think about is ECT, which many people think is not used anymore and is old-fashioned, but that's not true. It is used in very different ways than it was in the past. We don't have full-body seizures anymore, but it is electrical stimulation of the brain. There are also things like transcranial stimulation now, which are much lower levels of electricity and can be used even in handheld devices at times. We're not exactly sure, except that knowing that neurons are less active in people with depression, that probably introducing more electroactivity is simply increasing the activity level. In terms of psychological treatment, we're interpersonal therapy, which you may remember from the Paradigm chapter, really looks at those social supports and struggles someone might be having in those social factors. And then CBT, cognitive behavioral therapy, is going to come directly from those cognitive factors that we just talked about. And if you need to, you can go back and look at the CBT sample form that I gave you in that earlier chapter. But here, right, we're trying to increase that pause between your thoughts and your emotions so that you have an opportunity to challenge them a little bit. All right, and then lastly, let's just think about treatment for bipolar disorders. Medications we have here are different. We don't typically use those antidepressants to treat bipolar disorder, even though depression is a part of the experience. Here we use mood regulators, and so lithium is the oldest and still most widely used in many ways. And medication is necessary. We don't see treatment for bipolar disorder almost ever without medication. And again, right, we know about the high genetic etiology and therefore the high biological disruption that is part of the etiology for this disorder. Therapy often focuses on symptom management and helping the person to understand their disorder better. And we also might use CBT in some of the same ways, and also for managing that risk of hopelessness that we talked about and reducing the suicide risk. But the important thing to know is that for all of these mood disorders, with effective treatment and a combination of medication and therapy for many people, even very significant levels of these disorders are really highly treatable. So that wraps up this chapter for us, and we'll come with questions to our live discussion, and we'll talk more there.